Good afternoon and welcome to Providence Grand Rounds. We have a really fascinating topic today, sharing research on identifying factors that put patients at risk of long COVID. Next slide, please. Here are some of the meeting logistics. All the attendees are muted. If you have questions, please put them in the Q&A box. We do look at the chat also, but that would be the preferred location for questions. And this presentation is being recorded and will be posted on our Grand Round site. This is the continuing education information, and this will also be posted within the chat, so you'll be able to access that as we proceed. For disclosures, none of our planners have any notable financial relationships to disclose. Our two speakers are consultants to some companies that were listed there, and we'll briefly go over the learning objectives for today's session. At the end of the session, participants will have an increased ability to describe the syndrome of post-acute sequelae of COVID or PASC, also known as long COVID, recognize risk factors for development of PASC, which are listed there, define multiomics and explain the use of integrated data sets to understand complex biology, and discuss translational science and the rapid pace of learning in the COVID-19 pandemic. Next slide. And it's our pleasure today that our Assistant Vice President for Research and Chief Medical Analytics Officer, Ari Robacek, is joining us to provide a reflection, and then he'll introduce our two speakers. So thank you very much, Dr. Robacek.
Michael. Next slide, please. I thought that an interesting way to center us before we go into the subject is to actually hear from the voices of people who are suffering from long COVID. So I participate in a research project called My COVID Diary. We started right near the beginning of the pandemic. We reach out to patients via their mobile device after they have a positive COVID PCR test in our system, and we invite them to participate as citizen scientists and document over time in their own words what they're experiencing. And so thousands of patients have agreed to participate, and we're currently studying in depth 630 patients who continued to describe COVID symptoms at least 6 months into their illness. And so what I'm going to read are quotes from a group of different patients at around the 6th month of their illness. And again, these are verbatim, the things that they wrote. So this is what it's like to be a patient with long COVID. Next slide, please. On the right, what you see is just the part of the My COVID Diary user interface. Okay, so some experiences. Nothing new. Fatigue and absolute tiredness is almost unbearable, and it's hard to hold down a job. I continue to be exhausted and require more sleep just to work. Hard to do housework or work in the yard. Visits of 4 or 5 hours with family will require 3 days of extra sleep at night to recover. I don't visit many people, as that would result in missing work. I am tired. I don't have energy for so much I want and need to do. I'm trying to get my kiddo out for the things he needs, like therapy and social interactions, but even those are difficult. My whole body hurts and is stiff. It feels like my body is lead. I've been feeling this way for the better part of 6 months now. Every day is different. I have aches and pains that seem to rotate through my body. I wake up in the morning, I'm not sure which joints are going to hurt or whether or not I'm going to be able to breathe correctly. Nobody seems to care or understand that this is miserable. Next slide, please. Receiving headache upon headache, where before I hardly ever had one. Now I'm having them over 2 to 3 day periods. And my hair started falling out in late March and April. My hair is so thin you can see my scalp. I had a full head of hair before. Hair so thin, I have to wear a wig. I'm still too nervous to go anywhere. There are new strains out there that my vaccine might not cover. I can't take the chance of being sick again. Almost dying last time. I won't let myself get sick again. So, reflecting on that sort of very human aspect of long COVID, I know that I'm incredibly interested to hear the fascinating work that Jim and Jason have done to help uncover predictors that early on in patients' illness that this might be something that they're going to experience, so predictors of long COVID or post-acute syndrome of COVID. So here are our speakers. Dr. Jason Goldman is a practicing infectious disease doc at Swedish Medical Center in Seattle, and he is an epidemiologist, and he is a clinical researcher with a focus on infections in immunocompromised hosts. And something that you may not know about him is that he's also an electrical engineer trained at Duke. His research focuses on infections in solid organ transplant recipients and viral infections and immune responses in SARS-CoV-2, herpes viruses, hepatitis viruses, and HIV. He leads clinical trials and traditional cohort studies in virology. Dr. Jim Heath, our other speaker, is president and professor at the Institute for Systems Biology in Seattle. Previously, he was a professor at UCLA, and before that at Caltech, where he co-directed the Parker Institute for Cancer Immunotherapy. He's also worked at UC Berkeley and at IBM Watson Labs. So Jim knows biology and immunology and advanced computational methods and a lot of other things besides. He's also been named one of the top 7 innovators in the world by Forbes magazine, and he's founded or co-founded several successful companies. So it is my great pleasure and honor to turn it over to Jim and Jason.
Thank you, Ari, for that gracious introduction. I wish my mother was online so she could have heard it. So today, Jason and I are going to tag team you through a scientific story that unfolded over much of the past year, and which we published, I think, in early March in Cell, but which has led to a number of clinical trials that are now in the planning stage. And so, so we'll just switch back and forth. There's many folks that were involved in this work, and I've listed them here. I'm not going to go through them name by name, but this has been a major team effort, as has much of the science during the pandemic. Next slide. Okay, Jason, why don't you take us through the background of long COVID?
Sounds great. Thanks, Jim, and thanks, Ari, for those reflections about some of the verbatim quotes from patients who are suffering from a long COVID or past post-acute sequelae after COVID. I think those verbatim quotes really ring true to me, and in conducting the observational study that we teamed up with Jim and his team at ISB, we heard a lot of the same stories. These are surprisingly common in many patients who've experienced COVID, especially earlier on in the pandemic, but even into the later phases, these symptoms are really quite commonplace. And I'll go into a little bit of the epidemiology of that. Past or long COVID really affects multiple different organ systems. You can see some of the main ones listed here: the neurologic symptoms and the loss of taste or smell. Also, other very common symptoms like brain fog or inability to concentrate or focus. These are reported by lots of patients. Also, pulmonary and cardiovascular abnormalities are very common, as are psychiatric complaints and general symptoms, especially fatigue, but also myalgias, joint pains, headache, and many other things. And some of those quotes that we heard rang true to a lot of these symptoms. The figure on the right, the picture is actually a picture that was picked up by the New York Times covering our recent paper in Cell. This is one of our patients that was enrolled in our Encode study, and he actually got COVID twice, once very early in the pandemic, and then later, about I think around 8 months later, he got COVID again. But he got this tattoo as a reminder of what it was like to be on a ventilator. That's how he described it to me when we were reviewing his long COVID symptoms. Next slide, please. Here's another slide from a meta-analysis in Scientific Reports last year. This picked up on many studies that were describing the symptoms of long COVID, and just gives a sense of how frequent the symptoms are. You can see the most commonly reported symptom is fatigue in 58% of all the patients in this meta-analysis. Other very common symptoms are headache, anosmia or the loss of smell, dyschezia or the loss of taste, memory loss, and attention disorder are some of the sort of specifics of what is commonly referred to as brain fog. And many other complaints like cough, dyspnea, post-exertional malaise, they call that polyapnea in this study, and chest pain, joint pain, etc. Next slide, please. How common is PASC or long COVID? That's a kind of a matter of debate, but I think we're kind of honing in a little bit on an answer there. This is another meta-analysis that was published last year in JAMA Network Open, which looked at all these different studies. Each of these dots represents a single study from the country that's listed. And you can see the frequency of PASC is plotted on the y-axis, and the follow-up time from the acute infection is plotted on the x-axis. Sorry, the y-axis is PASC frequency. And you can see it's all over the map. It ranges from, in the teens up to, over 90% of patients at these earlier time points in white versus the middle time points. Most of these studies were very small, a couple hundred patients, but, this study did pick up one very large US-based study using electronic health record data. And in that study, the PASC frequency at around 90 days was roughly 35%. Next slide. Here's another good population level study. This was from the UK. It was a questionnaire-based study where they recruited through various rounds, up to 600,000 patients and waited for the first roughly 200,000 to respond. So, you get a good sample. These are around 75,000, study participants who reported a history of COVID. And you can see the vertical dashed lines here occur at 4 weeks and 12 weeks, and it's separated by men and women. You can see women have a higher prevalence of long COVID from these data and also other data find that same finding. But the prevalence is pretty high at 4 weeks. It's roughly 35 or 40% in men and roughly 50% in women at 4 weeks. And then by 12 weeks, it goes down to about 30% in men and about 40% in women. So this is actually pretty shocking how prevalent it is in these types of population level surveys. And even if you take a conservative estimate of how common the syndrome is, we're looking at this point in May of 2022, we're looking at 83 million Americans who have experienced COVID. And if only 10% of them develop long COVID, that's over 8 million Americans who are currently suffering from or who have suffered in the past from long COVID. So the magnitude of the problem is really huge. On the right here, this nice study did look at some of the factors that might be involved, and they identified sex, as I mentioned, but also BMI, so obesity or high BMI also associates with PASC. Next slide. Okay, Jim is going to talk next about our Encode study design.
Okay, so the basis of our study was to try to fill out this matrix. And so, you've got patients coming in our study 2 to 3 months post-infection with a variety of complaints. We took blood draws from these patients, both at initial diagnosis, about a week later at the stage of acute disease, and then at this time at convalescence. And out of those blood draws, and I'll show you in a second, we did just a huge number of measurements, almost everything you can think of out of the blood, trying to understand basically not just the nature of the acute infection, but the nature of recovery. And then we had this hypothesis that, not everybody develops PASC, and PASC probably has a lot of different disease etiologies, but are there different risk factors which maybe have the flavor of a causal factor that one can associate with the development of long COVID, but maybe you can actually measure them either late in the game or early in the game. It's going to turn out that we can measure them relatively early in the game. Next slide. So this is a complicated slide, but it shows you the blood draws that we collected for this particular study, and then you can look on the bottom. There's just all these different little drawings of the kind of things that we're measuring. Single cell analysis of whole transcriptomes on white blood cells collected from the patients, autoantibodies, antibodies, T cell receptors, B cell receptors, HLA haplotype, plasma proteins, plasma metabolites, a lot of things like that. So this is what's called multi-omic analysis. And of course, there's a lot of controls to try to understand the data. And on the next slide is to help guide you as we walk through what the data told us. I think it's oftentimes confusing to figure out of what analysis did what conclusions come. And so we've got these different symbols for electronic health records, or for the antibodies and autoantibodies, the plasma, metabolomics, proteomics, single cell, et cetera. And we'll keep those symbols with the slides as we present the data. Okay, next slide. And I'll pass it back to Jason.
Okay, so here's some of the presentation of the symptoms data at 2 to 3 months, that third time point that Jim mentioned in our study design. Our team at Swedish, led by Heather Algren and Julie Wallach. Julie's the lead coordinator, and Heather's our director of research. We queried all the patients in the study using a structured questionnaire and also an interview, and correlated that data with the EHR. As you can see from the figure, and we sort of indexed our findings to Ari's findings in My COVID Diaries to see kind of how commonly the symptoms were reported in our cohort. As you can see, they track really well together. And this tracks also with the other data that I showed about the long COVID epi earlier in the study, or earlier in the presentation. Next slide, please. This is a slide where we looked at anti-spike receptor binding domain antibodies. So these are antibodies that patients will develop in response to either natural infection or vaccination. In our cohort, almost all of the patients were enrolled before the vaccines were available. So these really represent the responses to natural infection. And what we find here is that patients do develop antibodies in a very characteristic way. There's an antibody specific to the receptor binding domain, or a separate cell-based assay looking at neutralizing antibodies in a cell culture model. And they correlate very well. That's the figure in the middle. And the receptor binding domain antibodies, the absolute level really tracks with the severity of disease. We see that in our data, and it correlates really well with many studies across the medical literature. The more severe disease you have, it tends to develop higher antibody levels. Thanks. Next slide. This is a matrix of using the symptom survey data on the x-axis there, with some of the comorbidities or lab results that can be found in the EHR. So you can see that there's some strongly associated or anti-correlated findings here in this matrix. But what we want to point out here is something that's very, very common, like diabetes, and almost all these patients have type 2 diabetes, very strongly correlates with different PASC, like cough, fatigue, neurological, etc. But some of the other comorbidities, which might be a little less common in the cohort, like coronary artery disease and others, the associations aren't as strong across the different PASC. And this might just be a feature of our study having, roughly a couple hundred patients in it. So, in some of the epi studies, it might be possible to resolve some of the comorbidities a little bit better than our study design. But as you'll see, the depth of our studies that Jim laid out is really the power of what we've done to resolve the underlying complex biology. Okay, next slide. So next, I'll talk a little bit about the assays done on plasma. And really, there were two main types of assays done here. One is proteomics, looking at almost 500 different blood proteins, and metabolomics, or looking at around 1,000 metabolites. And what we did is we mined the patient plasma for these protein and metabolite markers that associate with PASC. And these measurements were all done at the T3 time point. That's roughly when patients reach 2 to 3 months out from their acute infection. And the goal here was really just to provide some initial disease definitions. Next slide. Okay, So this PASC and PASC biomarker relates to neurological COVID. And as I presented earlier, many of the findings, many of the symptoms reported by patients suffering from long COVID are neurological in nature. And what we see is really the only plasma protein or metabolite that associates with neurological PASC is circadian rhythm proteins. And this is a metric that was based on the averaging of two different proteins that deal with the circadian rhythm. You can see very clearly here a very strong association with the neurological PASC presentation syndromes compared to healthy controls. And it's a graded response with any patient who had PASC up to patients presenting with neurological PASC. And this, is an important finding. I think we're going to see some interventions in the space already, and we'll talk about this a little bit later towards the end of the talk, is next steps are defining treatments for long COVID. Things like melatonin are being proposed to study in patients with long COVID based on findings that we've identified here. Next slide. This is another feature that we found in the plasma biomarker component of our study, and also one that I'm particularly excited about because it's essentially immediately actionable in the clinic. So what was done here was looking at cortisol and cortisone. And as you can see in the figures there, patients who are presenting with the respiratory viral PASC, and these are things like cough, shortness of breath, fatigue, headache, etc. They had lower levels of these stress hormones, cortisol and cortisone. So this was interesting to us. It kind of caught our attention because a lot of the symptoms of PASC kind of overlap or mimic those of adrenal insufficiency. In that syndrome, we see extreme fatigue, weight loss, low blood pressure, GI symptoms, muscle and joint pains, and other psychiatric symptoms like depression. So what I've started to do in my clinic in Seattle is to start to measure and see if I can identify adrenal insufficiency in patients suffering from PASC. So we can do screening tests for cortisol and then do ACTH sim tests. And if we identify adrenal insufficiency, that is actionable with replacement steroids. Next slide. We also looked to see if the low cortisol at the 2 to 3 month mark was associated with receipt of steroids during the acute COVID phase. Of course, that was one of the early COVID treatments identified. And what we see here is the first 3 boxes on the left are for cortisol and on the right for cortisone. And they go through the different time points: T1 at the acute diagnosis, T2 roughly a week later, and T3 at 2 to 3 months. What you can see is in those receiving steroids in red, their cortisol and cortisone are low at the T1 time point, but by T3, that resolves. So the cortisol received for acute COVID does not associate with the low cortisol state that we identified at T3. Next slide. All right. Also in the plasma compartment, we looked at a number of different viral infections. So of course, we want to look at SARS-CoV-2. The normal test for that, as I'm sure everyone here knows, is the nasal swab. But we also looked for SARS-CoV-2 RNA in the blood. We call that RNAemia. It's not necessarily a productive replicating infection in the blood, but it's the detection of the viral RNA in the blood. And we looked at 2 other viruses, both DNA viruses, herpes viruses, CMV, cytomegalovirus, and EBV, Epstein-Barr virus, which is the common cause of infectious mono. And we wanted to study these viruses for a number of reasons, including the fact that EBV was shown to be associated with long COVID, and CMV has some very strong associations with immunological dysfunction, both disease causing in those with immunosuppression, but also inducing of immune dysregulation. Next slide. And what we see in our data is that SARS-CoV-2 RNAemia, when present in the blood, is associated, when present in the blood at the acute time points early in the COVID-19 disease course, is associated with the later development of long COVID. And this is maybe not surprising. We've known since early in the pandemic that SARS-CoV-2 RNAemia is associated with more severe disease, and more severe disease is associated with long COVID. That's been borne out in numerous studies. You can see that in the figure on the right, that those with RNAemia in red have a lower survival probability compared to those without RNA from SARS-CoV-2 detected in the blood, who do better in terms of survival. I think that finding is maybe not surprising, but it's very important because of the implications of what can be done in an interventional way. So if the more RNA is present at the beginning, then that implicates antiviral treatment as very important to prevent long COVID. And again, we'll talk about this more later, but studies are being designed to this effect. I think what was potentially more surprising to us was the association with EBV. Now, herpes viruses like EBV and CMV are known to reactivate in critical illness. But surprisingly, we saw not really much in the way of CMV reactivation in our patient population, but we did see EBV reactivate. And in the blue, in this figure in the left, we see a kind of a summated metric of how much virus is there. So the blue represents EBV, and you can see that it was up at T1 at acute diagnosis, but then it gradually dissipates over T2 and T3. And this was associated with the later development of neurologic PASC. And we'll see that in the next slide, please. Here's a figure that looks at the SARS-CoV-2 RNAemia and the EBV viremia at the T1 time points and associates them with very specific PASC. You can see there on the x-axis in this figure. And I think what's interesting to point out in this figure is that the EBV does associate with some neurological PASC, like memory problems, very strongly, even when corrected for the infection severity. So this is important because EBV we identify as a factor in PASC, and it might be associated with the neurologic sequela of PASC or long COVID. And again, trials are being designed based on these data to intervene against EBV. And I think that this is a really important time point, for this finding, because, concurrently there has been findings that EBV is the trigger, the necessary but insufficient trigger for multiple sclerosis in a couple of very nice papers showing the epidemiology of that phenomenon and also showing the mechanism for that phenomenon, which is basically autoantibodies that are triggered by EBV that might be mimics of neurological proteins. So we'll get into this in more depth when Jim talks about the story we found in these data regarding autoantibodies. Next slide, please.
Okay, so I think most people by now have heard that autoantibodies are associated with disease severity in COVID. And this is a paper from the Rockefeller and French group showing the importance of autoantibodies, especially for type 1 interferons, in particular interferon alpha 2, for older individuals, and just how many of those, a very large number, that succumb to the disease. And so when we started looking for autoantibodies, we just wanted to look at a panel of autoantibodies, and this was an obvious candidate. The next slide is the justification for the other autoantibodies we looked at. So these are autoantibodies that I think many of you all who might treat patients with systemic lupus erythematosus would look for, so-called anti-nuclear autoantibodies and similar. And the reason why we look for these is because a year and a half ago, we published an initial cell paper on acute COVID. And what we found is a very novel set of B cells. They're called atypical memory B cells. And these B cells are B cells that mature. Generally, B cells will mature to produce antibody-producing B cell lineages and B cell follicles. But atypical memory B cells mature outside of B cell follicles, and they had been initially associated with lupus. But there are some associations with other diseases, but because of that, we thought, well, let's look for these lupus-based autoantibodies as well. The next slide. And so this is a rather complicated looking correlation diagram. And so let me walk you through it. So on the top axis and this upper right-hand quadrant is our study of 200 plus patients out over time. And then on the bottom left triangle is Helen Chu's study of her Harvey patients from UW. So, and then at the top left, we've got the antibodies against SARS-CoV-2, and this is the N protein, S protein, et cetera, and the various isotypes. And so for those of you who aren't familiar with these different isotypes, IgGs are the mature antibodies, and then IgAs and IgMs are different levels of that maturation. So if you just focus on the upper left corner, you see if you have one antibody against SARS-CoV-2, you have the other ones. That makes sense, okay? On the bottom right corner, now you're looking at all these autoantibodies. And in a similar, but with less correlation strength, if you have one autoantibody, your likelihood of having other autoantibodies is also high. And these lupus autoantibodies figure quite prominently here. What was striking is if you have more autoantibodies, if you track up to the top, straight up or to the left, you see that you actually are repressing the numbers of protective antibodies. Anyway, in other words, these two levels of autoantibodies or antibodies are anti-correlated. And in particular, it's these mature forms of the antibodies that are repressed. And so this suggested to us that patients that have levels of autoantibodies that are measurable, not necessarily what you would think of as clinical, but maybe even subclinical levels, can actually have an impact on how they develop a mature antibody response against the virus. And may explain why some patients get breakthrough infections that are quite serious, in addition to the fact that the virus is changing. Okay, next slide. So when you take these autoantibodies and you say, well, the levels of the autoantibodies, do they correlate with particular PASC? And yes, they do. By and large, they correlate with these sort of respiratory viral type PASC symptoms, not so much with the like sputum and GI and inability to exercise, not so much with neurological. And the next slide. So this goes, there's been a lot of literature out there asking, is the actual infection generating the autoantibodies, or do the autoantibodies pre-exist? And by and large, but not for all patients, by and large, these patients have mature autoantibodies at diagnosis, meaning they pre-existed the infection. And so it's a pre-existing condition for at least most of the patients. And when we now looked at the patients that have the very high levels of antibodies, now what would be considered clinical levels, we find that, and this data on the right is reflecting that, we find that those patients actually have elevated levels of these atypical memory B cells. So the upshot of this is that these autoantibodies are actually altering the disease journey for the patients that have them. And if they have higher levels of autoantibodies, that disease journey is altered more strongly. In other words, the autoantibodies appear to have some level of function. Okay, next slide. Okay, so we did a lot of single cell analytics. I'm not going to go through it in too much detail, but there was a couple of things that we learned that were very interesting for PASC, and it's just a huge data set. So I'll just walk through, I think, a relatively straightforward story. Next slide. And I'm going to focus on T cells here. And the reason why I'm going to focus on T cells is because T cells have a T cell receptor And because of experiments we've done in my lab, as well as with adaptive biotechnology, we've been able to identify lots and lots of T cell receptors, like almost 200,000 that are specific to the SARS-CoV-2 virus, as well as to other viruses. And those T cell receptors we can use as barcodes to track how the T cells are evolving over time. So what one expects to see in a T cell response to a viral infection is that, before the infection's there, you're going to have a naive T cell, a naive pool of T cell clones that are just basically waiting to find antigen. At the stage of acute infection, a few of these naive clones will expand and form effectors because they're out on the hunt, they're out to kill. But then after you've recovered, these effector T cell populations should contract back. And so using these T cell receptors as barcodes, we can follow what happens to viral specific T cells over time and see if all patients are the same or patients with different pasts behave the same, et cetera. And the next slide shows how we do this. So this is the population of basically cytotoxic T cells in all of our patients. And if you look at these colors, like this is on the far left. I forget that I can't point on my own slide. On the far left, so the deep red band, those are all the killer T cells, and the blue band is the naive ones, and then in between are the ones that form memories. So over time, in fact, what we do see for most patients is that cells are promoted from naive to effectors, and as the patients recover, they disappear. But not for all patients. And it turns out for patients that develop gastrointestinal PASC, as the patients are recovering, those cytotoxic T cell populations are continuing to expand. And it's not just for the SARS-CoV-2 specific cells, but it's also for CMV, cytomegalovirus specific cells. Now, there is no cytomegalovirus being reactivated by this virus. So the suggestion is that you have a lot of non-specific inflammation that is cranking up over time that's associated with gastrointestinal symptoms. And the gastrointestinal symptoms develop with a kinetics that is unique from the other paths. Probably it has to do with the virus taking time to become tissue resident in the GI tract. And at that point, there's basically some ongoing inflammation that's triggering T cell activation that, at least in large part, is non-specific. It's just chronic inflammation. Next slide. Okay, so this is, once again, it's not a simple slide, but I think the story is simple. So one thing that we hear from patients is that, they come in when they have developed these long COVID symptoms, and we know it's a very complicated puzzle to try to figure out what is the origin of these long COVID symptoms. Well, if we go back all the way to when those patients were diagnosed and we look at these past factors, it's the autoantibodies, it's the virus signatures, diabetes, et cetera, and we use our massive data set, we look, are these different past factors related to each other? And this plot on the left says yes. In fact, the autoantibodies are highly related to each other. The viremia from EBV and type 2 diabetes have some relationships. You can kind of resolve it if you look carefully. But then you look a week later, and those relationships are disappearing. You look out at convalescence, and they're completely gone. So in other words, if I looked at how these past factors are related at initial diagnosis, I might say that there is maybe 4 or 5 different treatments, 4 or 5 off at similar points, but because they have different comorbidities, different ages, they're different sex, et cetera, they just diverge, okay? And so it's very, very complicated and almost impossible when a patient actually is reporting PASC to be able to understand the origin of that PASC, unless you can actually go back in time and see that. Now, it turns out some of these pass factors that we measure, you can continue measuring symptoms of them or signatures of them at T3. But I hope that's clear, but it just tells you how complicated these chronic diseases can be once they're presented in the clinic. Okay, next slide. So if you looked at how important are these different pass factors in terms of predicting long COVID, well, EBV, viremia, SARS-CoV-2 RNAemia, and type 2 diabetes are all about the same. They all account for about 30% of the long COVID that we see, with the viral signatures accounting more for neurological pass and the type 2 diabetes more for respiratory viral. And then if you look at the autoantibodies on the next slide, they count for actually twice as much, almost 2/3 of the pass. So if I add all that up together, it's more than 100%, but that's because some patients had multiple pass factors. So I think many clinicians will actually ask, how come some of your patients have autoantibodies? We would expect maybe 2 or 3 to have autoantibodies if we, say, did a LabCorp test for autoantibodies. Well, that's because we're doing a quantitative test. If we looked at clinical levels of autoantibodies, as would be reported back by LabCorp, our numbers are about the same. But if you look at people that actually are positive for antibodies, say maybe 2 standard deviations above baseline, that's important for PASC, but those are subclinical levels. And so these quantitative autoantibody titers are important here. And so for sure, autoantibodies correlate. There's the strongest correlation with the development of long COVID, and higher autoantibodies tend to have a stronger impact as well. And this, of course, suggests, especially since many of these autoantibodies are associated with lupus, and we see other signatures with lupus, this suggests that the treatment available for lupus may be something that's worth mining for treating long COVID. And that's another thing that's under design right now as a clinical study. Next slide. Okay, so some caveats and limitations. Our study was extremely deep, but we only followed patients out to a few months. We're doing a much longer study now. We were limited to around 300 COVID-19 patients, but that separated into 2 independent cohorts, each of which validated the findings of the other. So what I could report to you, I think, is robust, even if it's still a limited patient size. We only looked for a handful of autoantibodies, these lupus ones and the type 1 interferon, but we're now interrogating autoantibodies against the full human proteome. Other ones may be important. Our patients were enrolled prior to the Omicron variant. We have patients now that we're looking at that were Omicron infected, but because of the mechanism of infection between Omicron and pre-Omicron, almost surely long COVID is going to have different manifestations, but we don't know what those are yet. And in this National Recovery Study, which I think Jason will cover, but we're doing this together with UW and other groups, really, goes orders of magnitude beyond the 300 patients we studied, and for very long periods of time. And I think this is the type of study that is really required to resolve some of the outstanding questions of long COVID, but also to provide the patient pools where some of the therapies that are suggested by our study can be tested. Next slide. And Jason, I'll let Jason describe the recovery study.
Okay, thanks, Jim. So yeah, as Jim mentioned, this is the national Recover study enrolling over 17,000 patients across the United States. And, we're teaming up in the Pacific Northwest Consortium with ISB, Swedish and other Providence sites like Everett and Spokane, as well as UW and others to study long COVID. And our consortium is going to enroll around 900 or so of the national 17,000. And what we do in this study, and here's a sort of screenshot from our website, our landing page for the consortium. Patients can go here and click Get Started to to indicate to us their interest. We're following them over time up to 3 or 4 years from their acute diagnosis, and doing serial blood draws, serial questionnaires, and depending on what people report in terms of symptoms and their clinical blood tests on the study, they might have other clinical workup triggered and helping to phenotype their disease state. Next slide, please. So here's a kind of a overall synopsis of the RECOVER study. It's a very complex, a big study with multiple different components. It has, as I mentioned, the different aspects of clinical questionnaires, of blood, serial blood draws to make a huge biorepository, and other clinical phenotyping, and different cores, including these clinical science cores, data research core, and biorepository cores, and different components besides the observational study, like an EHR cohort that's going to look at over 60 million patient records, a pathobiology studies core for this observational study that will sort of further the work we've done with the Encode study to look at the underlying pathobiology of long COVID, as Jim and I have detailed, as a kind of a disparate symptom, a syndrome at this point with lots of different underlying disease processes going on to contribute to the kind of potpourri of symptoms that patients are reporting, and also a tissue pathobiology study or an autopsy study. And one thing that we're really excited about is what's called RECOVER clinical trials. Next slide. This is going to be a adaptive platform study that's going to look at different domains of interventions to prevent or treat COVID. So we just submitted a response to a request for proposals for this from the NIH, and proposed 3 different clinical trials. And hopefully we'll be helping to design these clinical trials with other investigators around the country. And a lot of the domains that are being proposed for interventions in long COVID are domains that came out of our research in the Encode study. So for instance, I went over in detail some of the underlying virology that happens at the time of acute COVID and into long COVID. And these are domains that are going to be targeted for prioritization of interventions. So for instance, anti-SARS-CoV-2 antivirals will be likely studied to prevent or treat long COVID. Similarly, Jim detailed a lot of the findings from our study about autoantibodies that predict long COVID when they're measured early in the COVID-19 disease journey. And he also detailed some of the ongoing inflammation that we see in patients as they're recovering from COVID. And these will be studied in the RECOVER clinical trials in the immunomodulatory domains. And we've designed a number of protocol synopsises that can outline how these clinical trials will be designed. So this is really exciting. And we discussed the epidemiology. There's so many patients suffering from long COVID right now, and our patients really want treatments. And this is I think one of the major platforms moving forward that will help to understand which treatments will work for these different underlying pathobiologies and subphenotypes of long COVID. So thanks a lot. Next slide. All right, I think that's it.
Yeah, I'm looking for postdocs. So if you know postdocs, send them to me. Thanks.
We're happy to answer any questions. Well, thank you both for a really fascinating talk and for sharing the results of your study. There are a few questions that came in from the audience. Let me go through some of those. And the first, and I know yours was not an EHR study as well, but it said, have you seen long COVID symptoms in vaccinated individuals that were vaccinated prior to getting COVID? Yeah, I can take that one. Yes, we do see long COVID
in patients who are vaccinated. There's been a couple nice studies, mostly out of the UK, that have studied this on a population level. And vaccination definitely helps to prevent long COVID. It looks like, it reduces the development of long COVID by about half. But long COVID is still very, very common in people who get COVID. So that still leaves a lot of people not really very well protected from developing long COVID, even after they're fully vaccinated. And we're seeing this in the data reported in the medical literature. We're also seeing this in the clinic.
Thank you. Another attendee asked if you noted any association with blood type. They thought they had read that O negative individuals were less likely to develop PASC or long COVID.
I don't think we found that relationship.
Thank you. There's another question here. What is the relationship between long COVID and chronic fatigue syndrome, such as post-treatment of Lyme disease?
I'll answer that first, but Jason may have some comments as well. So I think there's a couple questions embedded in that. Before the pandemic, we were actually planning a Lyme study to look at post-acute Lyme, and I would study that completely differently now. Basically, I think these types of past factors that we're seeing here are very likely to pop up in Lyme disease. I think especially autoantibodies are going to be important, but other things as well. And so we would look explicitly for those to begin with. So I think this is the difference between post-acute COVID and post-acute Lyme disease. And one way of thinking is that we just have had the patients that have given us the blood and the time to allow us to really begin resolving what's going on in post-acute COVID. But I think other chronic diseases that come out of infections are going to have some very strong similarities. And I'll then pass it to Jason.
Yeah, as an infectious disease doctor, post chronic fatigue syndrome and post Lyme syndromes, very, very vexing conditions to try to understand and to treat. We know in Lyme, for instance, that it's not really persistence of active bacteria, but rather there could be persistence of antigen and certainly persistence of inflammation that causes some of the joint symptoms. We know that ongoing treatment with antibiotics does not help in post-Lyme. That's been studied and kind of resolved, but it's a little unclear how to deal with the ongoing inflammation. So I think chronic fatigue and post-Lyme, they've been around for a really long time. There just hasn't been, like Jim mentioned, the sort of the pandemic focus on them. I hope that kind of our huge amounts of funding that are pouring into long COVID and our focus on this will also be able to give a little bit more kind of direction on how to go with some of the other post-infection syndromes. But I'm really excited on the long COVID to sort of explore some of these similar phenomenon in treatments of persistent virus or persistent antigen. There's a lot of evolving research around this that we didn't have a chance to get into. But whether or not antiviral solutions for long COVID are going to work or not still needs to be tested. And I think what we're really, kind of excited about and maybe has a higher chance of success is some of the immunomodulatory domains. And hopefully what we learn in long COVID will have implications for the other post-infection syndromes.
Thank you. Another question that came in, can you get long COVID if your initial infection was asymptomatic?
Yes. We see in fact, all the associations that I and Jason showed you in terms of correlated autoantibodies, virus, what have you, with various long COVID symptoms, those were all corrected for disease severity and for age, for that, and for sex. We see that if you have serious disease, your odds of getting long COVID are very high. I mean, patients that were intubated, by and large, have very, very slow recoveries, at least in our study. But there's many patients that were asymptomatic that are getting long COVID symptoms. It's not a, it's serious disease is not a required prerequisite.
There's another question I'm not sure you'll be able to answer, but it says, was there any correlation with antibody levels and severe COVID vaccine reactions? But I know you may not have looked at that.
Yeah, we didn't have enough. It's an interesting question. We didn't, I don't think we had enough patients that, the severe vaccine reactions are fairly rare. They happen, of course. They're well known, but we wouldn't have caught enough in our studies to capture sufficient patients to know.
Yeah, and that's a great question, and we didn't explicitly study vaccination in this study that we presented to you today, but Jim and I did collaborate on another study called COVAX, where we looked at vaccine responses in immunocompromised persons. And we are looking into this idea about whether the antibody response correlates with the severity of reaction. So we call, in the vaccine literature, we call this reactogenicity, meaning symptoms after vaccination that are indicative of developing immune response. And these are things like fatigue, injection site pain, fever. These things commonly occur after vaccination, and they might be an indicator of how well the immune response is working against the antigens in the vaccine. So we're looking at that in our data, and I think other studies have also been looking at that. So I think I don't have a great answers to how strong that association is or not, but it's a great question.
One other question that you also might not have the longitudinal data, but the question came in: have you seen patients become severely ill with long COVID and make a full recovery? Any trends in those patients?
Yeah, so I can take this one too. There's some good news and some bad news here. The good news is that the symptoms do tend to wane over time. And we definitely saw this in our interviews with patients. Some of the symptoms went away completely. Many of them lessened in severity. And again, we haven't studied them, all the way out. But in that study from the UK that I showed at the beginning, after about, 12 weeks or so, the rate of decrease of symptoms isn't really that fast. So some of the symptoms might be more long lasting. We've heard kind of media reports about patients dealing with long COVID since the beginning of the pandemic. And I think some of the scientific data is bearing that out. So of the different pathophysiologies, some of the findings like tissue injury might persist. We've seen that very clearly in certain PASC, like the post-intubation interstitial lung disease. That seems permanent, and patients have undergone lung transplant due to the lung damage sustained from acute COVID. So certain PASC are going to be permanent, and many PASC will resolve over time.
Well, thank you. A couple more questions came in from the Q&A, but we have reached time, and perhaps those can be answered offline about the mechanism for reactivation of Epstein-Barr virus and whether markers of endothelial injury correlated with any of the phenotypes of long COVID. But thank you both for just a fascinating talk, and for telling us about the RECOVER trial that's going to be going on as well. It was incredibly informative, and really appreciate your time. Thank you, everyone, for joining us. And
Thank you.
take care. Bye-bye.